Okay, so I'm going to be talking about surveillance imaging and with a slight lean towards PET CT imaging. Okay, so I have no disclosures. So my objectives really are just to talk about surveillance imaging, basically when and why, which modality to use, and I've been asked to talk a bit more about PET CT. And then I was going to end off with talking about what we do in Toronto, and I put the asterisk there to sort of emphasize the fact that I'm just going to put out what we do. It doesn't mean it's necessarily right, and I'm sure it might generate some controversy or conversations. And I also had another goal was to finish in 12 minutes, which is what Suresh initially told me that I had. So, but now I'm told I had 15, so that's actually pretty good. Okay, so the first question that I asked, I actually had to give this talk about a year ago at another meeting, and the first thing that I asked myself, is there a consensus in surveillance imaging? And I work in Toronto at Princess Margaret, and I work with a lot of experienced radiation oncologists and head and neck surgeons and medical oncologists. And I thought, I'm going to be smart. I'm going to ask each of them what they do. I'm going to get this unified idea and story of what we do for surveillance imaging. And it's not surprising that I got things that were all over the place. And what I did after that, I thought, I'm going to ask my radiology colleagues from around the place. I asked Hilda, who unfortunately couldn't be here. I asked Suresh when he was still in University of Michigan. And again, there was really no consensus as to what should be done. So, I don't know if the battery's dying on this thing. Okay, so basically the bottom line is there is no consensus. I went to the literature. Again, I just wanted to find something that said, there is no consensus, and I found this paper. This was a paper dealing with oral cancer, and again, the bottom line was that there was no agreement for the need or for the interval for imaging studies in the follow-up of patients with head and neck cancer. So the question that I went to ask myself after that, I sort of took a step back. Basically, why do we do post-therapy and surveillance imaging follow-up? And things to consider is that the majority of recurrent head and neck cancer recurs within the first 2-3 years. And so we really have to be especially vigilant in this time. The risk of a second primary carcinoma of the digestive tract, synchronous or metachronous, can occur up to 20%, and that can take several years to arise. So again, we need some type of long-term surveillance. So the objective, so why do we surveil patients both clinically and with imaging? Again, the goal is to detect recurrent disease earlier, and the chances are that if we detect disease early, we can treat them more aggressively and have a better positive outcome. We want to detect new primaries and distant metastases, and we also want to image for post-therapy related complications. So how do we do this? Well, history and physical, again, very important to do, listening to our patients and seeing what they're feeling. And medical imaging as well is really important. And why? Rather than giving you papers that say why it's important, I'll actually show an example. So this is a patient that was treated at our institution, had oral cavity carcinoma, and this is the imaging examination afterwards. The patient was clear radiologically, and then he came back for his normal follow-up examination. He had a normal physical examination. He was completely asymptomatic, and then the clinicians decided, I'm going to image this patient anyway, and this is what was found. So you can see here, disease here, and then disease there as well. So again, this patient was completely asymptomatic, and if we did not do this imaging, this patient would have had a disease that would have been left to harbor and eventually progress and present. So what imaging options do we have? So again, we have plain films, CT, MR, ultrasound, and PET, but the ones that we use most in Toronto are CT, MR, and PET. So in terms of the current recommendations, so there's no consensus, but what does the Cancer Network, for example, say are the recommendations? So when I looked at this is what you see. So what they recommended is that for these cancers, so oropharynx, hypopharynx, glottic, supraglottic, nasopharynx, they recommended imaging, surveillance imaging for higher stage diseases, T3, 4, N2, and N3. In terms of the guidelines, they said anywhere from up to 6 months. So again, it's a broad timeline, and they didn't really mention the type of examination, the type of modality to use, and it doesn't actually take into effect HPV status, for example, which is a hot topic. So again, it's quite broad and open to interpretation. One thing that us radiologists would really like to sort of emphasize to our clinical colleagues is the importance of a post-therapy baseline scan. This is something that's really important. So depending on the modality that you're going to be using to follow up these patients, the baseline imaging scan could be anywhere from 4 weeks to 12 weeks, depending, again, on the modality. The thought is that by this time, any edema would have started to subside. We're assuming that if you've done surgery, there are tumor-free margins. And at this point, it's unlikely to have gross disease, especially after resection. And again, so at this point, which modality to use? Again, some people just say, well, continue using the same modality that you used in the past. And what I suggest is that, instead of saying, is CT better than MR, better than PET, overall, you really have to consider, the availability, the cost, the location of the tumor initially. For example, you have intracranial disease. At the initial stage, for example, you have a peritoneal tumor spread. Things like this would influence the best modality to use going forward. And also the patient status. If you have a patient who cannot lie still for 30 minutes for an MRI examination, there's no point in subjecting them to that modality. You can try CT or other methods. So in Toronto, what we tend to do, for example, we like to do CT for oral pharynx and oral cavity disease. We nearly always do CT for larynx and hypopharynx, and for complications such as osteoradionecrosis, we like to see those on CT. For example, here you can see a patient with osteoradionecrosis really nicely imaged on CT. And for MR, we like to do this for sinonasal tumors, NPCs, anything with intracranial or peritoneal disease. MR is really the method to go to sort of show that type of involvement. For example, here, there's a patient with temporal lobe necrosis following therapy. Again, MR really shows that really well. And peritoneal tumor spread, this is a patient with a neoplasm which had invaded into the mandible. You can see enlargement of the inferior alveolar nerve all the way up into the masticator space and back to Meckel's cave. So again, MR is something that we can use to visualize this. This would be really hard to visualize with CT, for example. And again, just to stress the importance of a baseline scan. So this is a patient who, again, clinically asymptomatic, came back for routine follow-up imaging. You can see had some surgery, parotidectomy, and neck dissection. And on this point, if you didn't have a baseline scan, I would ask, where is the recurrent tumor on this patient's scan? I know probably Suresh and Roberto probably can tell, but I'll just show you. So we had a baseline scan to compare with, and looking at that, we can see that the recurrent disease is that little small focus right there. So again, this really helped us in going forward to evaluate this. And another example, another patient, some surgery here. You can see a fasciocutaneous flap in the oral cavity. Again, patient was completely asymptomatic at this point. So I can ask the audience, where is the recurrent disease, or where's the tumor on this patient's scan? Look at the baseline that we had. You can see the tumor is this huge focused recurrence, and it actually nicely masked the appearance of a normal pterygoid. So you can see from here to there, it's quite easy. And this is the same patient on the coronal. Again, with the baseline, it's really easy to tell that that's recurrent disease. Okay, so the last few minutes I'll talk about FDG PET. So again, the basic premise of PET imaging is that we're using FDG, which is a glucose analog, and the thought is that tumors are more metabolically active. They'll take up the analog, and they'll sort of light up and show us where the tumor is. So again, is there consensus for PET CT surveillance imaging? Again, the answer is no. You can pick up any paper, recent paper on this subject, and they'll always have this byline that says, there is no current consensus as to when we should be imaging patients with PET CT in surveillance. So what I did is I went to the literature and sort of took various papers, and again, from these papers, I was going to try to tease out some things that we can sort of learn and sort of apply going forward. So this is one paper from Korea from 2007. This was before PET CT. This is just FDG PET. They're talking about routine surveillance for recurrent head and neck tumors. So what they did, again, it's a retrospective study, and all of the studies I'm going to actually be discussing, what they did is basically they have subclinical patients, so patients that really are clinically negative going forward, so really true surveillance imaging. And what they did is, depending on the paper, they would image the patients at various times, and they would follow those patients either with histologic confirmation, if it was available, or long-term clinical as well as imaging follow-up. So that's the basic premise of how all of these papers I'm going to be talking about. So this group, they looked at various head and neck surgeries, head and neck tumor sites, and in 156 patients, they imaged at these intervals. And again, And what they found, as well as a lot of the other papers found, is that the negative predictive value of PET is really high. That's the one take-home message. And they found that 97% of the true negatives had no recurrence during a median follow-up of 14 months. So from their paper, from their work, they concluded that they would recommend a PET scan at 6 months following therapy. And for subclinical patients with an initial negative PET, because of this finding, they thought, maybe we can start considering waiting a year or so before the next PET. So again, trying to tease out some objectives or other things we can learn from going forward. So that's what they sort of found. Another paper, this is from France, from a group in France. Again, this was now going to the realm of PET-CT, so again, using both modalities together, sort of combining them. Another retrospective study, again, various head and neck sites in 91 clinically negative patients that they were following up going forward. They imaged at 12 months. They found that 52 were negative. And again, they found a 100% negative predictive value. So all 52 of these patients turned out having negative disease or true negative disease. And they actually went to conclude that this was actually a more accurate method for assessing patients in the physical examination. And they proposed, not surprisingly, that they would recommend doing a PET scan at 12 months because that's when they scan their patients. Another example, this is from a group in the Netherlands. This is a prospective study looking at 48 patients limited to oropharyngeal and oral cavity disease. Again, they had clinical follow-up of these patients, and they imaged at these time intervals. And again, just like the other papers, validation by histopath or long-term follow-up, clinical as well as imaging follow-up. And they also concluded that PET was significantly better than the clinical evaluation. And again, 100% negative predictive value. And from their work, they concluded that they would recommend a PET scan somewhere between 3 and 6 months because when they look back at their data, that the scans they did at these 2 time points detected the most recurrences of their patients. This is a more recent scan from 2013 from the group in Pittsburgh. And what they did, again, a huge number of patients, 512 patients, various head and neck sites done for surveillance. So again, patients which are clinically negative going forward. And they followed these patients with at least 12 months of clinical and or imaging follow-up. They imaged at these time points. They found that they had a 91% negative predictive value for a negative PET-CT. They also found that if they had 2 patients with 2 consecutive negative PET-CT scans within a 6-month period, that only 2 recurred. So again, now they had a really high 98% negative predictive value. And based on what they found, they thought, maybe with this number and then satisfying, the 2 consecutive negative PETs within 6 months, maybe we can change or decrease the amount of imaging follow-up that we're doing. Maybe we can just go to the clinical surveillance imaging, or sort of clinical surveillance alone for a certain time point in these patients. So again, another thing that I sort of looked at, PET-CT and the status of the neck. So again, one of the dilemmas that we have when we image these patients who have big oropharyngeal carcinoma, massive neck adenopathy, when you treat them with chemorads, they sort of look like this. So you still have a little bit of something there. And the question is, what is that something? So PET has been really helpful and instrumental in evaluating and helping determine what we should be doing for these patients. Because of the setting where we are, I thought this would be a definitely appropriate article to sort of talk about. I think there's people on here that everybody sort of knows in this room who they are. So this is a study from Sloan Kettering that looked at 65 patients, various head and neck sites, chemorads. They imaged with PET-CT at around 8 weeks. Again, same premise, biopsy follow-up, imaging follow-up if available. And they, again, found for the neck a high negative predictive value of 97%, and also a high negative predictive value for the primary site itself. And based on their conclusions, they said, if you had a negative PET-CT in this cohort of patients, if there was no adenopathy or a small focus of adenopathy or residual disease visible on the CT, but negative on the PET, they can observe these patients. If you have a node that anatomically measures more than 1 centimeter, but it's still a negative PET, they thought, you can actually still maybe observe or consider a neck dissection depending on the comfort level of the physician and the patient. The last 2 things I'm going to show you, so again, these are 2 studies, again, looking at PET-CT and the neck in follow-up. One is a retrospective, one's a prospective chemorads to these patients. Both imaged patients at around 12 weeks, and again, negative predictive value, really high, 100%, 90%. This was a really interesting paper from Brisbane. They actually had a PET-directed policy. Basically, anytime the patient had a negative PET, they would observe those patients. Any patient with a positive PET, they went to neck dissection, and from this data, they were able to sort of get this type of information. So finally, so again, what should we be doing with PET then? So basically, from all that stuff that we saw, so basically, if it's available, you should definitely make use of it. That's pretty straightforward. The one take-home point is that the negative predictive value for both the primary and residual adenopathy is really high for PET. The timing of the scan, don't forget the baseline. You can try and incorporate a PET CT at that time. It seems like 3 to 6 months is a good time to sort of have a PET scan. It probably has the most impact. And if it's negative, again, that one paper I showed you, they thought, maybe you can wait 1 year before the next PET scan if it was negative in those patients, and follow with conventional imaging evaluations. And if you have 2 negative or 2 consecutive PET negative studies in a 6-month period, maybe you can start, again, maybe just moving forward with more clinical-based evaluations and image as needed. So another thing, this is my second last slide. So again, risk stratification. This is probably where the value of PET is going to be going forward. There's a lot of work being done on this. So again, metabolic tumor volume and total lesion glycolysis. These are sort of more volume-based methods to use PET to sort of assess the volume and the burden of the disease. And some of the preliminary work is that these parameters are predictive of response to chemo-RT and are predictive of patients with disease progression, recurrence, failure, and as well as death. And using these techniques, we can probably try and stratify patients. We can actually categorize patients and modify the aggressiveness of the therapy going forward, and even monitor or modify their rate of clinical as well as imaging follow-up. So my last slide, this is what we do in Toronto. Again, not to say that this is correct, but I just wanted to sort of throw out what we sort of have out there so you can have a patient with head and neck carcinoma treated with chemo-RT or surgery. For us as radiologists, please give us a baseline scan, and you can incorporate a PET scan in that scheme if you want. If it's a normal with a complete response, what the vast majority of my colleagues would do, they would follow these patients clinically. They actually incorporate ultrasound into their clinics. A lot of my colleagues, even if they had a normal follow-up scan, they would probably still do one more negative CT scan, for example, just to make sure that nothing was there. If you have an incomplete response for the primary or adenopathy, if you're really suspicious, some of my colleagues would go to biopsy, and if it's positive, obviously, it would lead to sort of salvage therapies. If it was negative, or some patients, they would actually be more comfortable with following, so they might actually repeat imaging in 4 to 8 weeks. Again, potentially they can use a PET CT. Potentially they would be more likely to do these for the patients who are HPV positive. Again, if it's abnormal, they might progress through this salvage pathway. If it was normal, that's great, and they would follow the patients clinically and with ultrasound. And of course, you would image at any time point based on symptoms and physical examination findings, which are worrisome. And I didn't show the paper, but there was one paper actually mentioning that maybe every patient with head and neck cancer should be having an annual PET CT to rule out distant metastases. That's, again, that's, I want to just throw that out there. Okay, thank you.